Good afternoon. Welcome to today's Wisconsin Health News virtual briefing on what's next for telehealth. My name is Tim Stum. I'm the editor of Wisconsin Health News. Thanks to all of you for tuning in today. We have a really great panel with us today to talk about this important topic. I'm honored to introduce Jessica Cow, an assistant professor with the Department of Population Health Sciences at the UW-Madison School of Medicine and Public Health, Karen Nelson, a vice president of strategic partnerships with UnitedHealthcare, Dr. Christine Waller, a medical vice president for acute care at Emplify, and Signa Meyers, vice president of strategic initiatives for Rogers Behavioral Health. Thank you all for sharing some of your valuable time with us today. Before we get started, I want to make sure we thank our very generous sponsors of the Wisconsin Health News virtual series. Healthcare leaders from across the state sign up to watch these virtual events, and they truly would not be possible without the generous support of these sponsors. So a huge thank you to Aurora Healthcare, AARP Wisconsin, Anthem Blue Cross and Blue Shield of Wisconsin, Amplify Health, Hush Blackwell, Quartz, and the Alliance. Wisconsin Health News is an online nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial, which you can do on our website at wisconsinhealthnews.com. And I want to give an extra thanks today to Aurora Healthcare, today's featured sponsor. We are really grateful for all of their very generous and continued support. Here to say a few words today is Dr. Jeffrey Barr, Chief Physician Executive for the Midwest region.
Hey, thanks so much, Tim. And thanks to all of you for the opportunity to welcome the group to today's session on the future of telehealth. Aurora Healthcare is honored to be the sponsor of the Wisconsin Health News virtual series, and we value the relationship we've had for so many years. Many of you already know who Aurora Healthcare is, but if I may, I'll take a moment to provide a brief update on who we are as part of the larger Advocate Health enterprise. Aurora Healthcare is the largest health system in Wisconsin and a national leader in clinical innovation, health outcomes, consumer experience, and value-based care. And as the state's largest private employer, the system serves patients across 18 hospitals, with our most recent opening this past May in Fond du Lac. We have more than 70 pharmacies and over 150 sites of care in the state. And in addition to Advocate Healthcare in Illinois and Atrium Health in the Carolinas, Georgia, and Alabama, Aurora is now part of Advocate Health, the third largest nonprofit integrated health system in the U.S. Committed to providing equitable care for all, Advocate Health provides more than $6 billion in annual community benefit. As part of our commitment to providing equitable care for all, we believe that virtual health is about creating greater connectivity and engagement between patients and their healthcare teams, delivering care how, when, and where individuals want it and can engage with it. We believe the value proposition of virtual health is this: more services to more people with greater convenience and accessibility, with better outcomes, all at a lower cost of delivery. And when we think about the impact of more services to more people, we know that virtual health is sustainably reaching into underserved rural and urban communities where access to services can be challenging, providing access to care closer to home than these communities have historically had. To share just a few stats, Advocate Health currently operates over 30 unique virtual health services. For example, virtual critical care, virtual nursing, virtual primary care, on-demand visits in primary care, and hospital at home, to name just a few. On-demand virtual visits, virtual school, and employer clinics join the ranks of those services. We've delivered over 1.6 million virtual visits to more than 8 states and 62 sites of service in the past 12 months. And we operate the nation's largest hospital at home program based in Charlotte, North Carolina. Simply put, we believe that people want and need greater connectivity with trusted healthcare information and teams to maximize their well-being. And we are fully committed to creating that connectivity, with virtual health being a key part of that. So thanks again to all of you for the opportunity to welcome you today. And I look forward to a very engaging conversation with our esteemed panelists. Tim?
Thank you. Thank you, Dr. Barr, and thanks again to Aurora Healthcare for all of the generous and continued support. Some great words to get us started off on. Thanks again to our panelists for sharing their time with us today to learn more about what's next for telehealth in Wisconsin. While telehealth usage is down from the heights of the COVID-19 crisis, it's up from before the pandemic and continues to grow. Telehealth is boosting access for services like mental health, but questions remain around reimbursement, broadband access, and cost. So we have lined up a panel of experts today to tackle these questions and more. Jessica, let's start with you to help set the stage. You've done a lot of research on telehealth. including utilization of telehealth. Can you just walk us through how utilization of telehealth has changed in recent years, from before the pandemic to the COVID-19 pandemic and to where we are now?
Sure. So our research team actually has been picking up this upward trend of telehealth, starting from our own partnered UW-Healthcare system. Actually, we started with a PCORI grant, actually focusing on the aging population who has been case managed under the healthcare system. But during the COVID, it hits in, and we started with one system of data set and moving along to see how telehealth has been changing. We would say over the first 3 months since March of 2020, when the national emergency started, telehealth has been increased more than 10, 20, or even 30 folds. Before that, on average, nationally, there were only about 6.9% out of all encounters who were being delivered by telehealth. And that's only limited primarily to commercial insurance, for example. Medicare hadn't been reimbursed telehealth by that point. However, starting the first couple months of 2020, when it's allowed for reimbursement, the utilization rate has been go up to almost 40-50% in that range. Up to the last quarter of 2023, the most recent update for the nationwide utilization has been ranging between still 10 to 30%. However, nationwide, there's still a lot of variations, with some states having on average telehealth or virtual delivery lower than other states.
And that's the national averages you're talking about in terms of, where we are now at the end of 2023, where is Wisconsin, and how's Wisconsin comparing to those national averages?
How is Wisconsin doing? So basically, if we take in the national reference of this 10 to 30% out of all total encounters, state of Wisconsin is very much consistent with the national trend. However, on average, currently, the last quarter of 2023, when we have access to the statewide data, our state average probably is at around 12.7%. It is slightly lower than the national overall average. However, if we decompose our telehealth delivery by different participating healthcare systems, we do see the wide variation in terms of delivery. We have a handful of care systems whose telehealth delivery is as low as 5% out of total encounters. And we also have around 10, 11 health systems who deliver telehealth at a range of 20 or 30%, very high.
And why, Wisconsin's in that average, but kind of the lower end of that national average? Why do you think that is? Why do you think that Wisconsin is maybe overall? It sounds like there's some big variation amongst health systems, but in Wisconsin, but overall, why is Wisconsin, you think, kind of a little lower than some other states?
Yeah, why Wisconsin is a little lower? Based on the national data, actually, the Congress estimate, not only Wisconsin, all Midwest area probably having on average lower than the national average of utilization. However, when we talk about the percentage, it's only like on average out of the whole population, when probably we decompose by different areas or different subgroups, the percentage also differentiate. And in particular for Wisconsin, why we see a little bit lower in terms of national average, I would say pretty much our state is proportionally more rural area than urban. And during this fast pace of telehealth expansion, a lot of delivery, we need to acknowledge that rely heavily on broadband access. And for a lot of cases, if we need audio-video interactions, we need smartphone or supported device, and which enters into really critical barriers for rural areas or rural places for people to get access to.
Thank you. And has your research yet shown or kind of drilled down in terms of what specialties or services telehealth is serving? I mean, have you seen kind of the variation in that? Are there certain services where telehealth today is being used more than others?
Sorry, my light gets
That's
off.
okay.
Definitely, I do not have very specific number across all care sectors, but I do see we have providers wise from behavioral health. Actually, I would say behavioral health has been and is always be the majority of the areas that are using telehealth. This is the case even before the pandemic. Before the pandemic, probably telehealth delivery has been very rarely in any other sectors than behavioral health. However, especially in commercial covered commercial insurance, telehealth for behavioral health consultation has been offered to the general public for a very long time. And even after the pandemic, when we see like immediate or huge increase, percentage-wise, we probably see the behavioral health telehealth encounter increase by a lower percentage, but only because it starts with a higher volume. But even after the great rapid expansion, currently we still have probably, I would estimate 60 to 30% of all encounters are more or less related with behavioral health.
Great. Well, thank you, Jessica. This is a kind of a great way to get things started. We will come back to you. Karen, I want to move on to you. You played you have played a lead role in UnitedHealthcare's telehealth efforts. Does what Jessica's saying just kind of generally track in terms of utilization, kind of what you've seen nationally and in Wisconsin, and in terms of what happened during the pandemic and what's happened afterwards?
Yeah, what Jessica shared is consistent what we see on a national basis. Pre-COVID, certainly there was very low telehealth utilization. It significantly increased in 2020 and has stabilized over the last couple of years. What we see in our commercial book of business is about half of all behavioral health is delivered via telehealth. And so that I concur is one of the great use cases for people to be able to connect and maintain their therapy and their treatment path virtually. When we think of telehealth overall, it is truly helping our members and consumers access the healthcare system and making it a shorter appointment time to see a care provider, providing a safe alternative from necessarily going into the ER urgent care. And so members and consumers have choice now to see their care providers, whether that would be virtually or in person, to support their best side of care.
Great, thank you. Dr. Waller, can you talk a little bit about Gundersen and Emplify's telehealth journey? I mean, how has utilization changed at your system, and where are things now?
Yes, thank you. So our telehealth journey actually started before COVID, just much like what Jessica and Karen also stated. And during COVID, we did see a surge of telehealth with stabilization, just like Karen had mentioned, over the course of the years. And our journey, we are largely talking about outpatient so far, but our journey also includes the inpatient component. And just as Jessica stated, with the rural areas that we serve within Wisconsin, we have found telehealth to be extremely important and key in being able to take care of our critical access hospitals. And by providing telehealth services, we've been able to keep patients closer to home on our inpatient setting, also offering a lot of support and being able to have different staffing models even, and in a very challenging environment when we talk about healthcare workers. So we, again, I echo what Karen and Jessica have seen. And interestingly enough, pulling our behavioral health data, we're over 40% of our visits are through telehealth and meeting the patients where they need to be met.
And how Karen, Dr. Waller, how are patients responding? I mean, is this something that they like, that they want? What's been the response from the patients receiving this?
So this is really interesting. We had a conversation. I've had several conversations lately, and patients really like the options. We're not saying that telehealth replaces the inpatient clinic visit, but it's a different mode of treatment. And so allowing patients to have access to different platforms is meeting the patient where their needs are. So giving an example. a mom with 5 kids, 4 or 5 kids, trying to get to an appointment. When it's a child or herself even may have an appointment that she could do online, allows her to stay in her own home in her own comfort and be able to take care of her family. Or putting it in another sense, she has to take care of her parent. She has to take off work. She has to go get her parent, pick her parent up, take them to the clinic appointment, find a parking space, walk in, and then do the same thing in reverse, and then try to get back to work. And what we see is that our patients and families do enjoy having the choices to be able to access healthcare in the way that they need.
So in terms of patient demographics, Dr. Waller, I'm gonna stick with you for one more question, and then we'll move on to Signa. But who's using this the most? As a parent, I've definitely found the convenience of using telehealth for a sick child visit. Is that demographic that's using it the most? Is it? I mean, what are you seeing at Emplify?
So that's really interesting. Pulling our data, you feel like it's probably going to be certain generations, but our 65 to 80-year-old population, that is where we are seeing the highest numbers of accessing telehealth. And thinking through it from that patient lens, it allows them to stay in their home, to have more autonomy. We are coming to them, and that is really where our largest population is right now. And so we're excited about those opportunities.
Awesome. Signa, how would you answer these questions? How has telehealth evolved at Rogers? What are some of the changes that the pandemic brought about in terms of telehealth at Rogers?
Sure. So as everyone has stated, obviously behavioral health has been doing a lot of work in the telehealth space prior to the pandemic, during, and now after. The difference, I would say, with Rogers and I guess the field is those higher levels of care, those higher acute, we were talking about outpatient, like we said, those individual visits with your therapist, individual visits with your psychiatrist. We were doing that before. What we had to figure out is, what do we do with those mid-levels of care? So for example, intensive outpatient and partial hospitalization for behavioral health, patients are in our clinics for 3 and 6 hours a day. During the pandemic, we need to figure out, how can we do this? We've never done it before. We had a lot of myths around that this could never be done. But what we found during the pandemic and post is that we were getting just as good outcomes with patients getting better as we were in the brick and mortar buildings. So post-pandemic, there's been a rise of the IOP and PHP, those higher acute patients.
And sorry, spell that out for us, Signa. Sorry.
Intensive outpatient and partial hospitalization. Those more acute needs, more than just a once a week session. You need to be there 5 days a week, 3 to 6 hours a day. Those companies are on the rise. So it's either Rogers, we're an established system, we started doing it more in the telehealth space, or companies started coming out of the woodwork, just providing intensive outpatient. Now, they didn't even exist before the pandemic, and they capitalized on this, higher acute patient that needs that higher level of care. So there's a lot more patients that have higher needs that are able to stay in their homes.
Do you think, Signa, has there been any, as you've transitioned some of this care to a virtual setting, has there been any drop off in quality by a provider, seeing a patient virtually versus in person? I mean, overall, how do you think that worked out?
Yes, that was very important for us during the pandemic and post-pandemic, to ensure that, if we're going to continue this, we want to make sure it's the same or equivalent to the in-person outcomes. So we do measure that regularly. We survey our patients every 2 weeks about their symptomology. And one thing that's, I think, special in the behavioral health space is the #1 predictor of a patient getting better in behavioral health is that therapeutic alliance and rapport that they have with their treatment team. So we measure that as well. That was like our, gold standard. If a patient can feel connected to their treatment team and therapist, as well as, as they are in person, then we've done it. And we found very little variation. And so we're very proud that therapeutic alliance continues even in the telehealth space.
Dr. Waller, what do you think are some of the limitations of telehealth? I mean, obviously there are some things that just can't be done virtually. But for those things that can be, I mean, is there any concern that the quality is not as high, that you could be missing something by performing a service via telehealth instead of in person?
I would say no. I'd say that the limitations really are understanding what the patient needs. And like you stated, some patients cannot be treated by telehealth and they need to come in. And I really say that the clinicians identify those patients well. And if there is a telehealth appointment and then the patient or the physician or clinician identifies that the patient needs to be seen, that can be a discussion. But I think that offering the patients telehealth does not change the quality. I like the way that Signa said that, and there's good literature to support that we understand that the quality can remain and looking at different avenues. But there are certain things that you cannot do with telehealth. There are certain physical examinations that must be completed and taking care of certain patients. And we understand what those are. So I wouldn't call it a limitation. I would just call it a change of the patient care plan.
Karen, would you agree with that? I mean, from an insurer standpoint and from what you've seen at United, I mean, is quality as good for care that's performed virtually as it is care that's performed in person?
Yeah, I think the evidence suggests that there's a lot of optimism on the ability of telehealth to maintain appropriate quality care and outcomes. I like to think of it as if you have a good care provider in person, you're going to have a good care provider who's doing telehealth as well. And so a lot of optimism there. I think that overall, when you look at quality and care, there's a lot of other evidence that shows that people with this new optionality are choosing the right site of service. So instead of going into the ER, for example, for a cough or cold, we're able to move that to a lower acuity method like telehealth. And so when you look at, all the different touch points that our members, consumers, patients have, it seems like they're able to help identify what's best for them to meet their needs. And so I think that when you look at telehealth being one part of the equation, that it is very supplementary to the total healthcare system.
Thank you. And Karen, what do you think this means though for overall costs? I mean, technology, building infrastructure for telehealth can be expensive, then maybe you haven't seen this, but there's some who have argued that, more telehealth may, ultimately mean more visits as maybe some care is provided more appropriate, but maybe for some patients it means extra visits. I mean, what have you found and kind of what are your thoughts in terms of what telehealth can mean for overall costs?
Yeah, we're still running some longitudinal studies, but initial data suggests that telehealth is not necessarily increasing cost of care. For example, if somebody was going to the ER, now it's a lower cost of care at telehealth. Another thing that we've seen as part of our 24/7 virtual urgent care, where you can connect with the provider oftentimes within 10 minutes, that particular member, right, doesn't necessarily need or may not, incremental lab testing if they went in person. And so you're looking at everything, kind of the total cost of care. And, we have a lot of optimism, especially as we move to value-based care and care for outcomes and making sure that we want people to interact with the healthcare system. We want people to do telehealth visits with their care providers when appropriate.
Thank you. Jessica, what do you think? Is telehealth cheaper or what impact is it having on costs?
I would not say telehealth is cheaper. It still take the resource and the very precious physician and healthcare workers' time to get everything going and a lot of supporting work to do. However, I echo Karen's point that it is a innovative way to deliver health and also can get around or address a lot of existing barriers to timely needs care and making up of delayed or missed care. And in terms of cost, it is more of trade-off. We cannot only, for example, limiting our site and say, oh, how much more expenses we put towards telehealth. We want to know if this portion of patient or encounters that haven't happened, where else would they go? Where would they go to seek for care, very likely they will present themselves in ED, in emergency department, or be hospitalized directly, which put even higher cost burden to the country, right? Some national number, just for reference, the most recent Congress updated budget for telehealth, if they give in current extension of telehealth reimbursement up to December of 2024, the calendar year of 2024 is expected to be 2.4 billion nationwide delivered for telehealth. Comparing to how much in total of healthcare costs for the country, 4.5 trillion. So it is much less than 1/1000th of total national healthcare cost. However, the potential cost saving for avoidable emergency department visiting or hospitalization could be way, way higher than that.
Thank you. Dr. Waller, what do you think? What overall impact do you think that telehealth can have on costs? And do you think telehealth ultimately leads to more or less patient visits, and why?
So I think the overall value of telehealth is actually multi-pronged, and looking at it from the access to healthcare. So really thinking about it from that lens, you have so many different ways to offer access to healthcare. Do I think it increases the visit numbers? No, I actually think that it allows the patients to be able to access the healthcare system, and like Jessica stated, possibly avoiding urgent care or the emergency room. I think it also allows those individuals and those patients who may not access care for maintenance reasons or need a medication check. They may say, I will go without my medications because I don't want to have to drive into a facility. It allows us to have that maintenance and that touch base with the patients. In the end, if our patients get the medications they need for chronic health problems or chronic health conditions, they're going to be healthier overall. So it provides a different lens of saying, what's the value? I think the value is multi-pronged. It's to the systems, it's to the patients, and it's ultimately also to the clinicians.
Thank you. Signa, do you think it's cheaper to provide virtual care than in-person care? Why or why not? And what have you found at Rogers?
Sure. So, cheaper to who? First, I'll talk about to us at Rogers. Absolutely. In terms of we're a specialty behavioral health institution, so we have to hire specialists in different areas. And so prior to this, if I just had an eating disorder specialist in Milwaukee, my folks in Appleton maybe wouldn't have access to that eating disorder specialty. So from my perspective, I can hire one eating disorder specialist and it could cover all of Wisconsin. And that's obviously probably the same case for the physical health specialist as well. But the second level of cost is the patient level cost, and cost in time, cost in burden, cost in work-related absences, cost in childcare. I mean, we've already mentioned it before, but people are busy. People have a lot of competing tasks in their life. And if we can just make this one easier way for them to not have to hop in the car, not have to travel, not have to find daycare, this is a lower cost for our patient.
Thank you. Dr. Waller, did you want to add to that?
I did. And thinking about our telehealth component and our access to physicians and specialized physicians, like Signa mentioned. So we had a gap with stroke specialists, and we were utilizing locums to fill in for our stroke treatment. And over the course of 2 years, we saved 52% by going to telestroke specialists. And we found out that their services, they were online within 4 minutes to help us take care of our stroke patients. So I would say that that is a significant cost savings for the institution while maintaining excellent patient care.
Karen, what would you say are some of the barriers that remain for further or widespread adoption of telehealth?
Yeah, certainly, as we think of barriers, the top one that usually comes to mind is the just access to the technology and broadband utilization. And so making sure that people we had brought up in rural communities have the same access as people in urban communities as well. And when we look at just the various kind of interconnectivity of the healthcare system, right? That telehealth has an opportunity to help improve that as well. We know that one EMR is one EMR. And so telehealth still, is part of a digital enablement as we look into the future. Having that connectivity between systems, between providers, allowing members to be able to access their information, interoperably are all things that are going to be really helpful as we go forward as well.
Thank you. Jessica, you've talked a little bit about this at the beginning of the program, but could you just expound on kind of what you found are some of the barriers that remain for telehealth?
Sure. I first want to echo for the barriers that Karen already identified. It's very critical to get equal healthcare access, and especially during this digital divide era. But I would classify that for the patient side of barriers. And equally, there's also barriers probably on the provider side or healthcare system. We need to acknowledge that certain healthcare systems, for example, smaller scale or those serving in rural areas may not having as much of financial or physical resources to build up the infrastructure supporting the telehealth delivery, which may yield later rolling in or adoption or penetration of telehealth being incorporated in their delivery or practice. Policy-wide, on the payer side, the payment policy also get involved in this situation. For example, Congress budgeting office always on debate whether we should extend our telehealth, being allow it to be reimbursed under public programs such as Medicare or even state Medicaid for guidelines. And such payment parity or reimbursement models actually will also impact and even relatively speaking heavier impact on those smaller health systems or even systems serving the rural areas. And those are the barriers that I would highlight.
Great, thank you, Dr. Waller. You serve a lot of rural patients at Emplify. How much is broadband access an issue to expanding telehealth, and what are some other barriers that you continue to run into in efforts to expand telehealth further?
Yeah, so infrastructure with broadband is a concern. We do have a very large rural community that we serve, and just talking with Nathan Franklin yesterday, and we were talking about it a little bit as to there's pockets where the great broadband service, and then you get into other pockets that you think you need to put 5 cents into the dial-up machine that you may not be able to get access. So really being able to bring a greater infrastructure for broadband would be very helpful for telehealth.
Signa, what are you finding at Rogers? I mean, what are some of the challenges that you run into in terms of expanding virtual health?
Sure. So echo what everyone else said, but one thing that hasn't been mentioned is digital literacy. Educating our patients on how to access, how to click on links, how to turn their camera on, what to do to problem solve, it is a big issue. And digital literacy affects our staff. So back when we had in-person care, therapists could just do therapy. Doctors could just do their med management sessions. Now there's an extra barrier. If you click on the link and your patient is struggling, that's now part of your job description. A lot of people are either upset with that, didn't expect that, or need to learn that is part of their job duties now. And it takes away sometimes from what you're doing, but we are trying to educate them as well. So that digital literacy piece is key.
So, Karen, let's move to you. Jessica's mentioned, that there are a number of Medicare flexibilities that have been in place since COVID. In terms of telehealth, that is set to expire at the end of the year. What do you think that would mean for telehealth if some of these flexibilities go away?
Yeah, I can't speculate necessarily what would happen in the policy space. I work in our commercial business, but ultimately we're committed to working with stakeholders across the industry to help simplify and just improve healthcare costs overall. We do have a robust state community health plan that serves Medicaid patients in Wisconsin and are serving them across all 72 counties. And so when I look at kind of the flexibilities and being able to serve all communities are critically important to us.
Thank you. Dr. Waller, what would it mean for you at Emplify if some of these flexibilities go away at the end of the year? What would it mean in terms of your efforts around telehealth?
I think it would slow down our telehealth expansion. And when we really think about the future of telehealth and what opportunities there are, I really think that we are really only scratching the surface of what we could do in the healthcare industry with telehealth. And so looking at if that were to end, I think it would slow down our progress. And I think that would be disappointing. I think the other part for us is that looking into the future, we're doing our strategic initiatives 5 to 10 years down the road and really trying to pivot and change course of direction of where we're heading. It definitely would change with the policy change.
What, Dr. Waller, what impact are our payment models having on the proliferation of telehealth? You know, a growing number of states are mandating payment parity for telehealth. Do you think that's important? Do you think that's needed here in Wisconsin?
So I think that is a question that I've been thinking about a lot about, I'll be honest, because we're offering excellent care. In a lot of situations, the clinicians are offering the same care that they would get if the patient was sitting in the clinic room. And to have a difference in payment models for telehealth, when it really goes back onto the patient complexity, what problems the patients you're addressing, the thought process of going into that. I may be reviewing labs, I may be reviewing images. They may not be sitting in the clinic room right with me, but the same expertise is going into those analyses and being able to come up with the treatment plans. So having a different payment model for telehealth versus in-clinic visits, I find it a little challenging. And I actually, as a physician, I find it really challenging because there are certain patient populations that the physical examination may not be what I need at that point. So I do think that different payment models could be challenging for telehealth patients.
Signa, what do you think?
Totally agree. I think if we don't have parity, there's going to be no incentive for companies like Rogers to expand and continue to innovate. We are still new in our journey for telehealth, and we need to continue to innovate. What telehealth is going to look like in 5 years, we don't even know because we haven't even discovered the technology yet. But if we pull back this reimbursement, no one is going to expand in that space and experiment and try new things and innovate.
Thank you, Karen. You know, United works in a number of states. In some states, you know, there is payment parity. Wisconsin, from the commercial standpoint, is not one of them. This mandate that telehealth services are reimbursed the same as in-person services. I mean, what do you think? Kind of looking at the states you've worked in, is that important? Is it appropriate as an insurer to pay the same for in-person services as you pay for virtual services?
Yeah, we ultimately pay providers per reimbursement policies, federal and state regulations, provider contracted rates, and variances in program. As one good example for our Wisconsin community plan that I mentioned earlier, we do pay telehealth Medicaid visits at the same rate as in-person and virtual for both behavioral and non-behavioral visits. And so there are some good instances within Wisconsin for payment parity.
Thank you. Jessica, what more do you think policymakers can do to improve telehealth and continue to accelerate telehealth?
There's a lot to do. Payment parity is definitely one important part to get the game going and get all the settings to make it incentivized compatible for all the players within the healthcare system to put in efforts into the place. In Medicare, for example, payment parity sometimes also get along to in terms of specifically the waivers that has been imposed during the COVID, is that telehealth gets reimbursed in a relatively higher rate for non-facility settings, for example, for clinics, providers in non-hospital-based situations. If the waiver has been expired, and which means these non-facility settings, physicians' clinics may be paid at a slightly lower rate than before, and that may make the service volume to be potentially decreased because it's not as motivated or incentivized as it's to be, right? There are some other limitations, for example, in relation to the telehealth restrictions, the government could impose or make permanently release of those restrictions in terms of, for example, whether patients are allowed to get their care at the comfort of their own home. Previously, there's restriction related to the originating set. Some telehealth is only reimbursable if it's delivered to patient or beneficiaries at designated centers who are offering telehealth. They are not allowed to be receiving care from home. However, if this restriction be waivers of these restrictions expired, we won't have such an option in the future.
Thank you. Dr. Waller, what more do you think policymakers can do to improve telehealth?
Like we mentioned earlier, I think the infrastructure around it being able to access telehealth. I also believe making policy more permanent. Like I said, the strategy for me, 2 years is behind me. 2 to 3 years is actually already behind. And I think Signa mentioned it too. If we're going to continue to innovate, and if we're going to continue to try to push forward and really think big and unleash all of our boundaries, I'm going to be strategizing 5 to 10 years down the road and beyond. And to look at what healthcare could do, how healthcare could change, how we could impact more people and how we can hit more patients and be able to take care of people while decreasing our physician burnout, which is, we know, a big concern, and being able to utilize specialists the best we can. I think making the policy a permanent situation would be very beneficial for the growth of telehealth and our patients.
Thank you. Signa, what more do you think policymakers can do?
Yeah, something that is important to us is the across state licensure flexibilities that went away. It is a big burden on health systems to have to license all of our clinicians and providers in different states. The burden is on us, right? And if my if my specialist lives in state A and patient is in state B, that's a problem. That's an access issue. But more importantly, sometimes our patients are traveling. Maybe they need to go to caretake for their mom for a week down in Illinois, and their provider is only licensed in Wisconsin. We are a mobile society, and likewise with staff. I have some staff that need. They would have historically taken FMLA to go caretake, but they could potentially work in another state and still see their patients. So that across state, we need to think about this nationally, not just state by state.
Thank you. Jessica, what impact has telehealth had on health disparities? Is it making it better by providing more care to more people, or maybe in some ways worse by providing a new option of care to only a certain number of people that have, the technology and the broadband access to access that care?
Sure. We earlier our research found there's disparities in terms of adoption rates across subgroup. But over these many years, since the very rapid expansion time, peak stabilization time, and currently since the utilization has been relatively stabilized across all subgroups, we would say we still see subgroup disparities in terms of utilization. But very interestingly, we see, for example, Asian or Hispanic group actually using on average higher percentage telehealth than the non-Hispanic white. So this suggesting some potential opportunity. Actually, telehealth does have this potential to increase access to care, not only timely access or specialist shortage, as we mentioned earlier. It does have the very vivid functioning to getting care accessible to the minority groups. And rural urban, earlier we mentioned before, on average, the national utilization rate in the rural area is much lower than the urban area. And very likely, we ascribe the reasons or explanations to be the broadband access or the supported devices, for example. There's also differences. We also some of our panelists also mentioned this earlier. Aging and disabled population actually have higher percentage likelihood of using telehealth than non-disabled population. For this specific group, aging and especially disabled, transportation barriers over time historically has been really obvious or really salient for them. So making telehealth to be a very good opportunity for them to leverage and to get timely and accessible care without thinking or worrying about the travel burden.
Dr. Waller, what do you think, what impact do you think telehealth can have on disparities, and what should health organizations make sure they do to try to mitigate any digital divide, amongst patients through telehealth?
I think as an organization, we need to understand the data and really look at our data to understand where, because what may be occurring in one system may not be actually what's occurring in another system. And looking at our disparities within our own system and then breaking down that data. So I think, first of all, just understanding the data and what our own systems show. What I think can help with that, again, is really also educating our public, educating our policymakers of saying this is what we are seeing, these are the areas that we have need, and sharing across the whole system. And like Jessica said, which I thought was an excellent statement, this is a national problem. We're talking about Wisconsin in our discussion here, and we've touched a little bit, but it really spans across the nation. And just thinking about a lot of other rural communities and other states. And I also like the comment about the state lines, because there are divides. And then we actually are we're traveling, we access another healthcare system, our records are somewhere else, where if we had the capability as a patient to contact our own physician and have a telehealth appointment across state lines, our healthcare would be consistent. So I think there's just a lot of really understanding the data, continuing to share the data, and continuing to be a voice.
Thank you. Dr. Waller, another national issue in terms of healthcare is unfortunately a rise in cyber attacks. Healthcare has become a ripe area for cyber attacks, with telehealth involving sensitive health data. How do you ensure that patient privacy and security are maintained? What are some of the main cybersecurity risks that are specific to telehealth?
I would say that really leaning into your informatics and your tech, our ITDS teams is really important, making sure we have solid partnerships, because part of their whole emphasis is really making sure our patients receive safe care. And when we say safe care, we don't just mean safe care as in how they're treated, but we mean safe care in the telehealth realm. And the system that we utilize with Cisco really ensures that it's a secure system. I will say, though, it's also educating our patients that they can't take their telehealth appointment while they're grocery shopping. To have that appointment time really needs to make sure that we maintain the confidentiality. And then, unfortunately, cyber attacks, we know, have hit the healthcare system and the pharmacy system, and they will continue to be risks, but making sure that we offer the safest patient options, I think, is going to be key.
Thank you. Signa, would you add anything to that? I mean, how are you approaching cybersecurity risks through telehealth at Rogers?
Yeah, I'll echo all of that. We have our own cybersecurity department, just because we know we're, ripe for picking, just like any healthcare. It's really for us. Vendor selection is really important for us, and vetting the vendors to make sure they have all their safeguards in place, HIPAA to name a few, but also letting our patients know when we're sending them information to sign paperwork, what it's going to look like. I mean, we have sample emails about what this will look like. If it doesn't look like this, don't click on it. So just like what Christine said, educating our patients is really important on what is safe, what isn't.
Thank you. And I mean, Karen, do you have anything to add to that as an insurer? What are some of the kind of unique cybersecurity risks through telehealth, and how is UnitedHealth approaching that?
Yeah, healthcare data and personal information are critical to serve our customers and protecting security and privacy. When we spoke of barriers earlier, the the barrier of somebody feeling like their information is secure and protected is, another one that comes up within some of our surveys as well. And so being able to focus, tying it back to policy regulations, HIPAA compliant technology, all these things are going to be critical as we go forward.
Excellent. We are kind of wrapping up to kind of conclude and kind of sum up what we've discussed. I'm hoping each panelist can answer this final question. But as we look ahead, what do we see as the future of telehealth? And Karen, we'll stick with you on this one. But where do you see telehealth, heading in the next 5 to 10 years?
Yeah, we think that the technology and telehealth will continue to advance, that more people will be using telehealth as a way to interact with the healthcare delivery system. And overall, our goal at UnitedHealthcare is to just help personalize a member's experience, make it simpler, to deliver better healthcare outcomes for the healthcare system, help people manage costs, and ensure that appropriate quality of care as well. We know telehealth is one part of the equation. We have the ability to incorporate the data, AI, and even use telehealth as an example in parts of our innovations, such as Surest, which is one of our plan designs that's a co-pay plan for members that doesn't have deductibles and co-insurance. And so tying together and creating a simpler healthcare system where people know what they're going to pay, be able to access that care, get that personalized care that's important to them, are all things that we see in the next 5 to 10 years.
Excellent. Thank you. Jessica, what do you think is the future of telehealth? Where do you see telehealth going in the next 5 to 10 years?
Sure. I definitely think telehealth will stay, as some of our panelists already stated this. Once started at such rapid and large scale, it definitely will stay. And research data already show that post-COVID up to 2023, and even emerging evidence in 2024, that we solidly using telehealth for up to 10, even sometimes 20% of all encounters. But what I would expect in the future is that telehealth be more carefully and retuned to be incorporated into regular care settings. For example, statewide in Wisconsin, we have around 30 participating healthcare systems who are constantly requesting us to offer some customized strategies or solutions. How should they, in particular, for their patient or certain patient groups, to incorporate telehealth for different concerns, for multiple chronic condition management, for inpatient care after discharge, for example, all different situations for all different subgroups. It needs to be very carefully investigated and making suggestions to move along for the future. A lot of research opportunities, I would say, sitting there and would want to be translated and using the evidence to translate the evidence-based research into the actual practice.
Thank you. Signa, what do you think is the future of telehealth?
Sure. So I think the concept of digital first won't be novel anymore. Digital first meaning they're never coming in person. It's not going to be novel, and customers are going to demand it. And we as businesses need to figure out how to meet that need in a safe, quality way. I would also say, even if something doesn't exist today, doesn't mean it won't tomorrow. So we need to continue to pushing like what our wish lists are, what are the barriers to making a whole digital first experience, and then we need to figure out who to partner with to create that. Remote monitoring is a big thing that I think is going to be in our space soon. Monitoring sleep, blood pressure, Bluetooth scales, heart monitors. I think that's going to be great to alert our providers when something's off. And then lastly, I would say using telehealth to integrate in spaces that we haven't before, specifically in the behavioral health field, like having us be integrated into schools, into primary care, into emergency departments, heck, even having us be at a library where people, if they don't have broadband, they can go to the library and have a quiet office and access care that way. We really need to come together as a community and meet people where they're at and get that care to them.
Excellent. Thank you. Dr. Waller, we'll give you the final word. What do you think is the future of telehealth? Where do you see telehealth 5 to 10 years from now?
I see a very strong platform for the care continuum of the entire patient. So where my mind goes is starting out in the EMS realm. Paramedic shows up on scene, would have access to telehealth, going to the emergency physician. That all of that information can be transferred. Patient go ahead and comes in. Patients in-house, we're using virtual nursing, we're able, and then we're able to discharge the patient, or while the patient's in a rural setting, they're utilizing telehealth to have a physician that's mentored or a clinician that's even mentored into a rural setting, expanding our rural setting care. And then once the patient goes home, this is the whole care continuum, we would have telehealth options to meet the patients where they're at. If we have a freshly immunocompromised patient or someone that has just had a transplant, meeting them where they need to be met. So looking at the whole care continuum, even as our population ages, being able to access that, but having a significant platform with the infrastructure is going to be very important with our policies.
Excellent. Well, thank you all. This has been great, very informative. We really appreciate your valuable time today. Thanks to our generous sponsors for making this discussion possible. We'll be back in person for our next event, December 10th in Madison for our annual hospital CEO roundtable. As always, you can find more information in our daily email newsletter. Well, thank you all and have a great, wonderful day.